Good day, everybody. Our talk today will be on bleeding in early pregnancy, and it will be in two parts, part one and part two, to make it much more easier for you and for the logistics of the recording. So we'll start with part one. Bleeding in early pregnancy, in general, could be due to causes related to pregnancy and others non-pregnancy related. We are going to deal with those who are pregnancy related, which are miscarriage, ectopic pregnancy, and molar pregnancy. The non-pregnancy related could be cervical polyp, urethral caruncle, cervical ectropion, and hemorrhoids. Our talk mainly will be about the pregnancy-related causes, though those others can cause bleeding in early pregnancy, but the concern will be about miscarriage, ectopic pregnancy, and the trophoblastic diseases. Miscarriage, by definition, entails the expulsion of a pregnancy embryo or a fetus at a stage of pregnancy when it is incapable of independent survival. It cannot survive if left or if delivered on its own. So that made a time limit of all pregnancies losses before 24 weeks. Any pregnancy loss before 24 weeks, we call it a miscarriage. We have to differentiate here between a miscarriage and an abortion. A miscarriage is spontaneous, without any intervention. An abortion, which we used to use the term before, is when it's being induced, whether for medical reasons or for other reasons. So our talk here about the one that occurs spontaneously. We talk about the epidemiology of miscarriage, whether it's related to the gestational age, in advanced maternal age, or past obstetric history. If we take the first one in relation to the gestational age, it is known to decrease with gestational age from 25% at 5 to 6 weeks to about 2% after 14 weeks. That's to say, the more the pregnancy advances, the less the chance for a miscarriage. That's as far as the gestational age. The maternal age also, rate of miscarriage in prime gravity over the age of 40 is higher, approximately about 30 to 40%, compared to that of prime gravity who are less than 40 years of age, coming to about 6 to 10%. In other words, the older the lady, the more likelihood is that the pregnancy may end in a miscarriage. The third factor is the past obstetric factor, and that's shown by recurrent miscarriages. If she had recurrent miscarriages of 3 or more, then she is more likely to have miscarriage in the next 25 to 30 pregnancies. So the epidemiology were related to the gestational age, maternal age, and the past obstetric history. What causes it? What causes miscarriage? Almost 80% are due to chromosomal abnormalities. 80% of all abortions, whether miscarriage or induced, okay, then are due to chromosomal abnormalities. Other factors which we know are endocrine factors, uterine abnormalities, maternal infection, especially when it occurs early in pregnancy and an acute one, psychological factors, immunological factors, drugs, and environment causes. So we go on one by one of these and see almost 80%, as we have said, are due to chromosomal abnormalities, which could be diagnosed, of course, after taking the products of the abortus and then doing chromosomal analysis on it. Common causes or common chromosomal abnormalities: Down syndrome, triploids and tetraploids, monosomy, that's Turner syndrome. So these are the common. Down syndrome, a lot of them will be miscarried or aborted. Turner syndrome and others. Translocation, which is hereditary. We go to the endocrine factors. The endocrine factors include diabetes, hypothyroidism, luteal phase deficiency, and polycystic ovary syndrome as an etiological cause for a miscarriage. So chromosomal, endocrine. Thirdly are uterine abnormalities, congenital anomalies of the uterus, like uterine septa or bicornate uterus. Another condition that leads to endometrial adhesions, which we call Asherman syndrome, what occurs after excessive curettage for a miscarriage, to the degree that the basal layer has been removed, that will be followed by formation of adhesions, eventually amenorrhea. If she conceived, the likelihood of a miscarriage is there. That is the Asherman syndrome. Fibroids, submucous fibroids. And we know fibroids could be submucous, intramural, or subserous. Subserous and intramural rarely affected, but the submucous myoma is the one that could cause it. Maternal infection, especially in early pregnancy. And these are the organisms that could lead to miscarriage. Listeria monocytogenes, Mycoplasma hominis, Ureaplasma urealyticum, cytomegalovirus, and toxoplasmosis. So if any one of these occurs early in pregnancy, the chance of a miscarriage is there. The fifth group are psychological, then immunological. And the immunological one, we are worried about systemic lupus erythematosus, antiphospholipid syndrome, and when there is histocompatibility between the mother and the father, and in turn the fetus, which is a rare situation. But antiphospholipid systemic lupus erythematosus could lead to miscarriage. The other factor, or the seventh factor, or etiological factor, drugs and the environment. Drugs, one that cause miscarriage, quinine, used for the treatment of malaria. Nowadays, we use drugs other than quinine. We don't revert to quinine unless the others failed. It's known to cause miscarriage. But the point we stress here that if a lady with malaria and she needs quinine for the treatment, don't hesitate, give her the quinine, because the fever and the malaria are equally deleterious or bad for the fetus as well as the mother. So if there is no other drug to use except quinine, please do that. Other drugs, ergots, severe purgatives, tobacco, alcohol, arsenic, lead, formaldehyde, benzene, and radiation. So female working in radiology department, they have to protect themselves, protect the ovaries, and to protect the uterus if they conceive, because it could cause miscarriage beside the other anomalies that could be into it. So differential diagnosis, or what types of miscarriage we know of: threatened miscarriage, inevitable, incomplete, complete, missed, septic, and recurrent. The first four are in a progressive way, from being threatened to an inevitable one, then to an incomplete where parts of the conceptus has been passed, or a complete one. This is just how we look at it. We see here types of the miscarriage. We'll go through this again. If it is a threatened miscarriage, you normally find the pregnancy inside the uterus. And if you do cervical or vaginal examination, you will find the cervical os closed. And if you do an ultrasound, you can hear the fetal heart. It is heard. The fetal heart is there. So threatened, cervical os closed, fetal pulse within the uterine cavity, and the fetal heart is heard or seen. And inevitable, products may be felt, but they are coming down, as you can see here. Here is well fixed there, here it's coming down. Then the cervical os will be open, and the fetal heart may be heard or may not be heard. If you go to the incomplete, part of it has already been passed. So the os will be open and there will be no fetal heart because already the part has been passed. If you go to the complete one, the uterus is empty. Here in the incomplete, there are some products still within the uterine cavity. In complete one, the uterus is empty. The os is closed here because already the products has been passed. And obviously, there won't be any fetal heart. If you go to the missed one, the product of conception is there, but it's dead. So the os will be closed, but there will be no fetal heart. You won't see it. We are just going to go in, we will go in detail about all what we have mentioned, but this picture just to make things easy to remember. So when you go into the history of a miscarriage or the clinical features, we take the general for every miscarriage, and then we take the clinical feature of each and every miscarriage. Generally, we take the history, general examination, speculum examination, ultrasound examination. Then we do laboratory investigations, mainly beta HCG, blood group, CBC. We may need to give anti-D, and then you do urine general. Management in general, expectant, medical, or surgical. That depends on the type of the miscarriage. There are categories we have just shown in the picture earlier on. So we take them on by threatened miscarriage. As we have said, there is pregnancy. Symptoms and signs of pregnancy are there, There is vaginal bleeding, which is slight. If you do the beta HCG, it is normal for gestational age. That's to say, when we ask for a beta HCG, the laboratory usually quantify it. They give you a quantity that it is so and so. And then at the same time, a comment whether that's corresponding to the age or not. Or they may say that this corresponds to the age of so many weeks. So you have to compare that with the gestational age. In threatened miscarriage, the normal beta HCG will be for the gestational age. The pregnancy will be intrauterine. As we have said, the cervix is closed and the fetal heart is positive. Just what you have seen in the picture earlier on. And the pain is minimal. So signs of pregnancy, minimal bleeding, minimal pain, then intrauterine, os closed, fetal heart positive, beta HCG normal. Treatment for threatened miscarriage, expectant. Rest for at least 1 week after the stoppage of the bleeding. So ask the patient to rest, whether in hospital or at home. And she has to stay resting for at least 1 week after the bleeding has stopped. No sexual intercourse for 2 reasons. Mechanically, it could affect, and the second one is the prostaglandins in the male semen. They could lead to stimulation of uterine contractions. So avoid sexual intercourse. Some obstetricians give progesterone or progestogens. Their role is controversial. Very few people are using them now because we don't know, or we are sure that it is not going to be effective unless there is a real deficiency in progesterone. So we go to the next category, taking the picture in your mind. Symptoms and signs of early pregnancy coincide with the duration. Okay. But vaginal bleeding here is excessive, and it may be accompanied by clots. There is pain. And as we have said earlier on, the internal os is dilated, and you may be able to feel products through the internal cervical os. The fetal heart may be heard or may not be heard, depending on what degree the miscarriage has gone into. That is the inevitable. Treatment of inevitable: resuscitation. She may have heavy bleeding that you may need to give her blood. You may need to give fluids. Then give ergometrin intramuscularly or intravenously. That leads to stoppage of the bleeding and probably expulsion of the fetus or the products. Expulsion of the products. Then after resuscitating her and giving her fluid, blood, and ergometrin, the final management depends on the gestational age. If it is less than 12 weeks, then you can do vaginal evacuation and curettage, or suction evacuation, classical evacuation and curettage, or you do it through suction. More than 12 weeks, we have to give syntocinon IV drip to expel the uterine contents. If the placenta is retained, then it could be removed under general anesthesia. Also, if after giving the syntocinon, she expelled the products, but not completely, you will need to evacuate the uterus. So resuscitate, depending on the gestational age, will be the ultimate treatment. The third is incomplete. As if you remember the picture we have shown, the patient usually notices the passage of products. Most of the patients usually bring to you what they have passed. And you have to be sure that it is a fleshy thing and not a blood clot, because she could have severe bleeding that causes blood clots that could simulate, or at least she may feel that this is part of the conception. So passage of the products is there. Bleeding is continuous. When you do examination, the uterus is less than the dates, or the uterine size is less than the dates. If you remember, we said that the cervix will be open and the products may be felt because still some are there. Ultrasonography show usually the retained products. You won't be able to see fetal pulse or fetal heart, sorry. You won't be able to see the fetal heart. And as we have said, the os is open. Excuse me. The treatment is evacuation of retained products of conception. So this is the incomplete form of a miscarriage. If it is complete, all products of conception have been expelled from the uterus. So you'll find the uterus empty on ultrasound. The bleeding is slight and gradually diminishes and ceases. The cervical os is closed because the product has already been there. And obviously, there is no fetal heart because there are no fetal tissues at all there. The uterus is slightly larger than normal for the non-pregnant uterus. So complete, all the products have been passed, minimal bleeding, ultrasound, empty uterus, examination, os is closed, no fetal heart or fetal thickening. Ultrasound, empty uterus. Once it is complete and the ultrasound shows an empty uterus, there is nothing more to do. You don't have to subject the lady to any surgery. Okay. The other type is missed miscarriage. It means that the conceptus has died and retained in utero for 4 weeks or more. Retention of dead products of conception for 4 weeks or more. We call it missed miscarriage. It could go to another stage further to be called carnea small. It is a variety of missed miscarriage in which the dead ovum or fertilized ovum early in pregnancy, it died and become surrounded by clotted blood and stayed there. We call it carnea small. In most situation or in all situation, miscarriage means that the fertilized ovum or the conceptus has died and being retained in utero, whether there are some blood clots around it early on or without. Symptoms of a missed miscarriage. Symptoms of threatened miscarriage may be present or absent. Symptom of threatened miscarriage, we have said mild bleeding occurring and mild pain. Usually there is regression of the pregnancy symptoms, such as nausea, vomiting, and breast symptoms. In a missed miscarriage, they regress. She won't have any nausea or vomiting, and the breast symptoms of early pregnancy usually disappear. The abdomen does not increase and may regress, and obviously because the pregnancy is not growing. So it is there, either smaller than what it is, or just as it's normal. Fetal movement, if they were there, they will cease, they won't be felt. Or from the start, they are not felt. If it's less than a certain age, because we normally say between 18 and 20 weeks of pregnancy, the lady feels the fetal movement. So if the fetal movement was already there, it stops now. But if it wasn't, then that it is not there. Milk secretion may start, especially in the second trimester. Normally, the breast during pregnancy produces colostrum till delivery. Then after that, it changes to milk. Colostrum has its value for the first 24, 48 hours after delivery for protection to the fetus from certain diseases, which you will know, and the advantage of breastfeeding over bottle feeding. Missed miscarriage, low beta HCG for gestational age. As I said earlier on, they give you a quantitative value and they tell you that this is equivalent to so many weeks of pregnancy. So here, the beta HCG is less than what is expected for the gestational age. There is an intrauterine gestational sac. It is usually collapsed with absent fetal heart. So you may see a collapsed gestational sac with no fetal heart. The gestational sac, if it is more than 20 millimeters, there will be no fetal pole. Will be no fetal pole. Or if there is a fetal pole which is more than 7 millimeters, there will be no fetal heart. That's to say, this is normally expected. Gestational sac more than 20 millimeters, there should be a fetal pole. Fetal pole more than 7 millimeters, there should be a fetal heart. You don't see that in the missed miscarriage. What worries us is the complication of missed miscarriage, and that is disseminated intravascular coagulation, which could occur if the fetus is retained for more than 4 weeks, or if there is superadded infection. Treatment, either spontaneous expulsion or evacuation of retained products of consumption, or we can give prostaglandin E2 analogs with or without mifepristone. So spontaneous, surgical, medical, all comes into it. Septic miscarriage, any type of miscarriage or abortion, usually, when you say septic miscarriage, it could be a septic abortion because it is a type of a miscarriage or an abortion which is usually criminal, complicated by infection. So it's an induced one. Septic miscarriage spontaneously is not very common. The common is septic abortion, where it means that the abortion is being induced. In most of the cases, criminally induced. Infection are bacteria, E. coli, Bacteroides, Streptococci, Clostridia, Strep, and Staphylococci. Septic, this is the picture of it. Septic abortion, pyrexia and tachycardia, rigors suggestive of bacteremia. If she went into a state of near shock or collapse, temperature will be subnormal. So the temperature could be either hyper or low. There is malaise, sweating, headache, and joint pains, jaundice and hematuria, indicating hemolysis, abdominal pain and tenderness, abdominal rigidity and distension, indicating peritonitis. Local examination, she will have an offensive vaginal discharge. Complications of it, septic shock. And that may develop into severe complications like acute renal failure or disseminated intravascular coagulation. Those are symptoms starting from milder things by temperature, and they could end up with acute renal failure or DIC. Treatment: isolate the patient and bed rest. Establish an IV line or central venous pressure line, depending on the condition of the lady. Do full observation of vital signs, intake output, then give antibiotic therapy, fluid therapy, blood transfusion if needed. Anti-gas gangrene and anti-tetanus toxoids. Then oxytocin infusion. That's to do both control the bleeding and possibly enhances the expulsion of the retained products. Following that, you do surgical evacuation, and you do that usually 6 hours, minimum of 6 hours after the start of the antibiotic. That's to say, cover her with antibiotics, do all the necessary measures of resuscitation, then you can do surgical evacuation. In certain situations, you could go up to the level of hysterectomy. Recurrent miscarriage definition: 3 or more consecutive miscarriages occurring before 20 weeks of pregnancy. Possible causes: recurrent miscarriages, advanced age, as we have said earlier on, age more than 40 for a primary gravid who is over 40 years of age, she is likely to have miscarriages and recurrent miscarriages. Genetic, something like parental chromosomal abnormality and fetal aneuploidy. Miscarriage could also be caused by endocrinopathies, uncontrolled diabetes, thyroid autoantibodies, luteal phase deficiency, polycystic ovary syndrome, antiphospholipid syndrome, where you have to make lupus anticoagulant and anticardiolipin antibodies. Other possible causes: thrombophilic effects, factor 5, Leiden deficiency, factor 2, activated protein C resistance, protein S deficiency. All these are related to coagulation and related to probably recurrent miscarriage. Immune response: excessive uterine natural killers. Uterine abnormalities, whether there is a bicornate uterus, bacterial vaginosis, infection, and torch. We believe that torch has a great responsibility, or a big responsibility, in the recurrent miscarriage, but nowadays investigations show that torch infection has a limited place in the causes of recurrent miscarriage. Torsolae toxoplasma, rubella, cytomegalovirus, and herpes. The 10th one is the cervical weakness, leading to recurrent miscarriages in the uterus. Investigations: You need to do male and female karyotype, antiphospholipid, immunoglobulin M and immunoglobulin G, lupus anticoagulant, factor 5, activated protein C resistance, transvaginal sonography, follicular FSH level, insulin resistance. All these investigations should be done wherever it is possible. And another one is the hysterosalpingography if she is not pregnant or at the end of the pregnancy after she has miscarried. She came to you with a history of recurrent miscarriages. We do hysterography to see the cervical os. Is it really tightened or is it like funnel shape? Treatment depend on the cause. The good one we can treat is antiphospholipid syndrome, an inherited thrombophilia causing recurrent miscarriage. Treatment here is aspirin and or heparin, all through pregnancy till about 2 to 3 weeks before the expected date of delivery, and then you stop it. So in this, you give aspirin or heparin. Progestogens or progesterone is controversial to give in a recurrent miscarriages. It means that is not yet proven value. Not only that, what has been proven is that it has no effect. The last one is the cervical incompetence as the cause of recurrent miscarriage. And here the clinical picture, diagnosis and management. Clinical picture of cervical incompetence, and no, classically it is a mid-trimester miscarriage occurring initially with the passage of fluid, very little pain, followed by the miscarriage with very little blood loss, something like a normal labor. The initial thing was the fluid coming is the amniotic fluid. So it occurs by the cervical incompetence. The membranes bulges through it, they rupture. After that, the pregnancy will be aborted, and it's usually mid-trimester. Diagnosis, mainly we depend on the clinical picture, but after delivery, we can do hysterography or hysterosalpingography to tell us the cervical os. And during pregnancy, we can do ultrasound to measure the cervical length or the competence of it. Management of cervical incompetence is surgical. Either what we do is Schrothker stitch, the classical one, or McDonald stitch. Means surgically, at the beginning of the second trimester, you insert a stitch around the internal os, and you leave it there to hold the pregnancy to be removed at 38 weeks before the lady goes into labor. So classical picture, diagnosis, either ultrasound or X-ray when she is not pregnant. Treatment is cervical cerclage. Thank you very much, and we'll stop here at the first part of our talk. Thank you.